Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host, Rachel Frank, a sports and shoulder surgeon at the University of Colorado in Denver. Rachel, how are you?
Doing well, thanks, Pete. How are you today?
Oh, I'm doing good. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, the University of Colorado, or the institutions of any of our guests. Today we have an episode for you on the American Board of Orthopaedic Surgery, or the ABOS. We've invited two guests on to speak about their work with the ABOS as well as the role of the ABOS largely within our field. First, we invited on Dr. April Armstrong. April is a shoulder and elbow surgeon and is currently the chairman at Penn State, and she's the president-elect of the ABOS and is the chair of the ABOS Written Examinations and Graduate Medical Education Committee. April, welcome to the podcast.
Thank you. Happy to be here.
And next, we have Dr. David Martin, who currently serves as the executive medical director of the ABOS. David, welcome to the podcast.
Thank you. It's great to be here.
I wanted to get started by asking each of you how you became involved with the ABOS. So, April, how did this start for you? How did you first become involved with this organization?
It was, I'm going into my 6th year now as a board of director, and so I remember getting a call from Larry Marsh about almost 6 years ago where he had indicated that I had been nominated for the ABOS board and then subsequently informed me that I had been elected as a board of directors. So I do think that it probably was related to a lot of the work that I've been doing with the AOA and involvement with resident education, and so it's been truly an honor to be involved. And so I think all those that were involved with the recruiting and also the election.
And how about you, David? How long have you been involved with the ABOS? How did you first get involved?
Well, I've been involved with the ABOS since the early 2000s, and I would credit my mentor, Chris Harner, who around that time was starting to look into subspecialty certification in orthopedic sports medicine. And I assisted in question writing and then got involved in helping the ABOS with the oral examinations and various other volunteer positions. And I was elected to the board as a director in 2005 and served on the board for 10 years. And then shortly after leaving the board, the executive medical director position came open. And actually, Larry Marsh also called me then and thought I might be interested. And so I'm now the executive medical director there. I do that 4 days a week, work at the board, and still maintain my practice at Wake Forest 1 day per week. So it's a pleasure and a privilege to be involved in the board certification process. I think as professionals, we're given the opportunity to self-regulate, and I think we should take that very seriously, and that's the work of the board.
Let me ask both of you, and this might be a pretty simple question, but I think a lot of surgeons, especially later on in their career, or maybe even early on, wonder this, and you guys are going to have the best perspective. Why do we need the ABOS? April, let's start with you. Why do we need the ABOS?
Well, one of our primary missions is to protect the public. And so the ABOS is really the certifying board to demonstrate to the public that orthopedic surgeons in our nation have met certain standards with respect to their skills and their knowledge and their behavior. And so it really signifies to the public, who can then look up their surgeon to show that they have the stamp of approval, really that they meet the expectations that we would really expect for anyone treating our friends or our family. So I think that's our primary role.
And David, what are your thoughts? What would you say to surgeons who question, why do we need the ABOS?
Sure. I think that's a great question, and it's one that we get very often. And I think I would start at the same place that April did, our founding principles were to serve the best interests of the public and our patients and our profession. And the wisdom of the Academy and the AOA back in the early 1900s to look at orthopedic surgery as a profession and a field and decide that a separate body was needed to look at the qualifications and the preparation that orthopedic surgeons went through to get to the practice in the field, I think was a very bold move and showed a lot of wisdom to create a separate independent organization. And I really feel that while some people would say, well, I'm a practicing orthopedic surgeon, I'm doing the right thing, I keep up with the literature, and I attend meetings and do the best for my patients, that may all be true. But I think if the American Board of Orthopedic Surgery stepped out of this role, someone else would step in. And as I said before, we've been given the opportunity as professionals to self-regulate. And I think our programs are for orthopedic surgeons, by orthopedic surgeons. And I think I would say that someone is going to look at certification and board certification or some type of regulation in our field. And I believe strongly that that ought to be done by a group of dedicated orthopedic surgeons who have a lot of experience in our field. And that's exactly what we have on our board of directors.
So now, David, you described a group of orthopedic surgeons. Tell us a little bit about the structure of the organization. You've mentioned that you're an executive medical director. You were on the board previously. How big is the board? How's the board composed? How does that entity take place?
Sure, that's a great question. And we are an independent organization separate from the Academy. And we are basically served by a national board of directors. And that April is a member of our board of directors. That includes 20 orthopedic surgeons who serve a 10-year term. And we have one public member who serves a renewable 3-year term, or really a 6-year term. So our board of directors is 21 members. They serve on a volunteer basis. They're all, the orthopedic surgeons are practicing orthopedic surgeons, and they participate in all the same board certification processes. So they set our direction, they set our strategic plan, and look at all of our programs. Then in Chapel Hill, we have our board offices. We have been remote for a lot of the time over the past year and a half, although we now have a hybrid work plan that started just this month. But we have 12 staff members, and I am the executive medical director, and then we have various staff members in fields of certification, in fields of graduate medical education, program directors, those types of things, communication. And we carry out the work of the board. So that is a full-time job for those of us who are there in Chapel Hill, and there are 12 of us. And then we also enlist consultants, the National Board of Medical Examiners, the American Board of Medical Specialties helps us. We have outside legal help, outside IT help through a company called Web Data Solutions in Chicago. So we do use consultants for a lot of our work, but that's the basic structure. And in doing that, we serve the approximately 30,000 orthopedic surgeons who are in the United States and are board certified.
So now it sounds like, April, then you're one of 21 orthopedic surgeons. You said you're 5 years in, so you're probably halfway through that term. From your perspective, what has this been? I mean, I understand it's a volunteer thing, so I'm sure it's a lot of time for no pay. Tell us what you do on the board.
So each of the board members is appointed to different committees. So we have various committees: an oral board exam committee, written exam committee, GME committee, credentialing committee, and then there's other subgroups that there's a research committee and other subgroups. So I've been mostly involved. When you first become elected, you are on all a lot of the committees just so you can see the structure of the board, but then in your second year, you're really relegated to specific committees. So I've been mostly involved with credentials, written committee, as well as the GME committee. So the written committee, this is really for the written board examination. So this is a certifying Part 1 exam that the residents will sit for in July. And there's a pretty robust process in developing that exam, and it takes about a year or a little over a year to develop that exam. And then as far as the credentialing committee, we meet on a regular basis, and this is where we review concerns raised to the board about some of our candidates and our members. And then we also have the GME committee, which has been really involved with developing standards for knowledge, skills, and behavior, and measuring resident performance. And so this has been a project that really started off the ground about a year before I started on the board, and we've been collaborating with the AOA and CORD, and we're at the point of onboarding hopefully all of our residency programs, which is about 197 across the nation, to really implement the measurement tools that we've developed through the Knowledge, Skills, and Behavior program. And I could go into more details, but I'll maybe stop at that point.
One question that I think a lot of us are wondering is about the structural changes that ABOS has recently made for maintenance of certification. I think many of us have been excited about some of these changes. Can you tell us a little bit about what has changed with the MOC in the last several years and what drove this change? How do you think it's working out? And do you see that continuing forward? David, let's start with you.
Sure. That's a great question. And what I would start with is to say, maintenance of certification, you hear many people say it's very onerous, it's hard to understand, and hard to follow. And what I would say is that we've tried to streamline and simplify it, and really it's not all that complicated. It's essentially, we look at it as 4 parts. So an orthopedic surgeon has to have professional standing. So we look at an orthopedic surgeon's licensure. They have to hold a valid state medical license and have hospital admitting and surgical privileges. We look at their continuing education as the second part. So an orthopedic surgeon in a 10-year cycle has to do 240 Category 1 credits of orthopedic-related CME, and we'd like 40 of those to be self-assessment examination credits. We can get into that if you'd like to talk about that more. The third part is a knowledge assessment. Up until about 5 or 6 years ago, that was basically an examination, and that's some sort of knowledge check once every 10 years. And then the fourth part is improvement in practice, and in every 10-year cycle, we obtain an application, and using that application and also using a zip code list, we obtain peer review from an orthopedic surgeon's peers, and we also collect a case list that involves either 9 months or 75 consecutive surgical cases, and we evaluate that. That's the whole MOC program. And, I would say if someone said, hey, what kind of a surgeon is Dr. Frank? If I, knew about your hospital privileges and your license, I knew you were keeping up with your continuing medical education, you had some sort of knowledge test, knowledge check, and then I looked at your cases and talked to your peers, I think that's a pretty good way to tell our patients that particular surgeon is meeting our standards. The things that have changed the most are in that knowledge assessment, and that generally has been a multiple choice examination. When I came on the board 6 years ago, we had a general examination, and we had sports, hand, spine, and adult reconstruction. And so you had to pick one of those and take that exam, or you could do an oral examination, which is based on your own cases. Orthopedic surgeons told us they didn't like, for instance, if they're an adult reconstructive practice, they didn't want to study pediatric orthopedics again and take that general exam. So what we did was created practice profile examinations in each of the subspecialties in orthopedic surgery. And we started by getting groups of experts together and putting together blueprints for those examinations. So what should a practicing shoulder and elbow surgeon know? And we made that blueprint first, and then we built examinations based on those blueprints. So now you can choose an examination in your subspecialty and see only questions from that subspecialty. And the blueprints, or, when we're ready to take an exam, the first question I ask when someone says there's going to be a test, I'd say, what's on it? And those are the blueprints that are published on our website. So that was one way we tried to meet people at their practice. Still in all, a test in a testing center, is a high-stress situation. And as we looked into adult learning principles and honestly looked at what other boards were doing, we came to the conclusion that we should look into a longitudinal assessment type program. And so that caters more to adult learning, allows people to do that on their own and choose how and where they want to be examined. And that program is now entering its fourth year. It's called the ABOS Web-Based Longitudinal Assessment Program, and that involves knowledge sources, which are generally journal articles, and there are anywhere from 150 to 200 of those that we put on our website each year. Each orthopedic surgeon, if they would like to participate in that pathway, can choose 15 of those and study those, and then in a 6-week period in April and May, we administer 2 questions per knowledge source. It's a very simple platform. Orthopedic surgeons can go at their own pace, and they need to score 24 out of 30 questions correct. The questions are open book, and that involves a quality year. In the 10-year cycle, if they obtain 5 quality years, that satisfies that knowledge assessment portion. So that's been the biggest change, and we now have, last year, 14,000 people participated in that program. And so that's been very successful, and people really like that, being able to choose a knowledge source, a journal article or a practice guideline, study that, and then have questions directly from that source. So that's been the main change, and April may want to talk about some of the changes that we're making in the area of graduate medical education, because that's also been very exciting.
Yeah, well, April, why don't you tell us a little bit about that and tell us where we're going with that aspect of and the ABOS involvement there.
Sure. So this was the GME committee work that I was just talking about, and this was in collaboration with the Academy and the AOA and CORD, and so it's called the Knowledge, Skills, and Behavior Program. And so the knowledge portion of this, we've actually worked alongside with the Academy, and we've integrated the blueprints with the OITE exam, which is the in-training exam, with the blueprint for the Part 1 examination. So we've aligned with that. There was a group meeting last February to develop that blueprint together with a lot of experts in every different subspecialty in the room. And we also integrated questions as well with the OITE. So the OITE subgroup that writes questions submits them to the board. We then place those questions on our Part 1 exam to vet them out. Those questions that perform well will then show up on OITE examinations. And then those questions will not be shared back to the residents. Traditionally, all questions were sent back to the residents so that they could learn from their mistakes and from things that they knew well. But at this point, we're holding back these questions because these will then act as kind of standard setting questions across many years to come so that we can see how residents have performed year to year. And so it really helps us to identify a standard so that we can actually then compare how residents perform across our nation. And then also set expectations for the residents and programs. For the skills program, this was really initially developed by Anne Van Heest and a subgroup with the with cord and AOA. And essentially, they looked at the feasibility of a surgical skills tool called the OP tool. So it was a combination of two different tools that were already out in the literature and that had been validated. And so they ran a pilot study across 16 different programs, and were able to show that the tool, so this is basically a web-based tool where the residents request faculty to evaluate them right at time zero. So within 48 hours of them doing a surgical case, the resident can get feedback about this case, and there's different various criteria. And those then go into a database and a dashboard for the residents, so they can then track their performance. And Anne and her group, their work has shown that you can show that there's performance improvement across PGY level years. So for instance, a PGY 5 will perform at a higher level than a PGY 2, which is what we would expect, but the tool is able to show that performance as well. The third part of the program is the professional behavior program, and this is a program where I was involved with. Again, it was a collaborative group with AOA and CORD, and there were 18 different programs that ran the pilot. And so essentially this was a new tool that we needed to develop, and so it's a 5-domain tool where we look at different aspects of behavior. And we ran the pilot to see if it really would identify the outliers, so those residents that actually weren't necessarily meeting the behavioral standards that their colleagues were. And we showed that 97% of the residents actually performed pretty well. So they would score, it was on a 5-point Likert scale, they would score 4 or 5. So in general, we suspected this would be the case, that most residents are going to perform well with behavior. But the purpose of it was really to identify those 3% of residents that weren't performing as well. And now that it's kind of divided up into their domains, it also helps programs target performance improvement programs for the residents. So if you had issues with communication, then you would know where the behavioral issue was, and you can help develop them within that domain. So it's really a full package for the knowledge, skills, and behavior, and we are hoping to get all of the residency programs on board with this. Eventually, we want to look at big data. This is something that, if people aren't aware, that the general surgeons have actually been using a tool called Simple, and they've shown that they can track performance, and they can show that residents, by the time of their residency programs, that they actually are in fact competent. So I think it was really a great vision of the board. They had recognized just before I came on with the board that when we sign off on a resident before they sit their Part 1 examination, it really was based on time, and it wasn't really based on performance. So the whole idea is to get away from necessarily that time-based performance and more competency-based performance.
I love the idea of getting away from just, well, you've been here for 5 years, so we might as well call you a surgeon. So it's such a cool thing. It's complicated, it sounds like, and I think we're all curious to see how it's going to play out. It certainly sounds like it's going to be better than what we're doing now. One of the questions I wanted to ask is about the way COVID has affected the way the ABOS performs the in-person test. I know it's forced the ABOS to make that transition from board eligible to board certified, often called step 2 or the oral boards, virtual. Tell us, do you see that shift to virtual being permanent? How is that gone? How is that going to play out in the future? What do you think, David?
That's a great question. We were pressed by the pandemic, but at the same time, we felt like, and our board felt that, if board certification is important in normal times, it's even more important during a pandemic. So we felt like we really needed to make the effort to continue with all of our programs, and we have been able to do that. The oral examination, as you know, consists of an evaluation of an orthopedic surgeon's own cases. So we look at a case list, we choose 12 cases, and what that has come to, many of us who have somewhat more gray hair than others remember carrying a big pile of records and a big pile of x-rays to the Palmer House in Chicago to take the oral examination. And that has now all been digitized. So the 12 cases are all uploaded onto a platform. And when it became clear that we were not going to be able to meet in person, we did what we called a case-based evaluation. And we had piloted that in Chicago based on those uploaded digital records, so that while individuals were taking the oral exam in person, we had other examiners look over their case documents and their case images and score them, and we were able to correlate those fairly well with performance on the oral exam. So that's what we did in 2020 for the whole group, is look at their records without them being present, and using the experience that we had from several years prior to that, we were able to move a group of those people to a passing position. A second group we looked at with a virtual oral exam done by Zoom. And then we had a third stage to that, where all of that information was then reviewed by our directors. This year in 2021, we did that case-based evaluation in July. And I would give a shout out to all of our volunteers. We had nearly 400 examiners go through cases and an immense number of documents and images, and score all those all in a 1-week period in July, which is pretty amazing. Orthopedic surgeons have really stepped up. And we were then able to pass a group of people, and the people that were left over from both of those experiences in both 2020 and 2021, we brought back to Chicago for a standard oral exam that we did last month at the Palmer House. And we did that with required vaccination, social distancing, masking, and actually were successful in getting slightly over 500 examinees through that process, and had nearly 200 examiners come to Chicago and help us with that process. So we're proud of that, and I know that doesn't answer your question as to what we're going to use moving forward. But not to dodge that question, our plan for 2022 right now is to have a standard oral examination in Chicago in July. Obviously, we're watching the pandemic as everyone else is, so that may change, but that is our plan. And then over the next year, we really need to evaluate what parts of our pandemic modifications worked really well and what didn't work really well, and what we're comfortable with and what we're not comfortable with, and then apply those going forward in the future. So I think certainly we have learned a whole lot about how to evaluate someone with that particular platform, and that will be useful in all parts of our board certification process. And how that relates to the oral exam, those are questions that we're going to start answering in the coming months.
Certainly kudos to the board for overcoming what sounds like a huge challenge to try and shift to virtual, shift back to in-person with vaccinations, et cetera, et cetera. Let me ask you, April, you're the president-elect, you're coming into a leadership position here. As we've heard about a lot of changes to maintenance certification at the graduate medical education level, the step 2 level. What other changes do you see coming in the future for the board?
That's a really good question, as David would say. I think that, like most people in most of their areas, whether it's medicine or not, I think we're going to think again about how we do things. So David just talked about how we had changed completely the oral examination. I think that for the written examination, the same thing. We changed a lot of processes, and we now implemented some virtual aspects that I think will be a permanent change. for us. So I think that just looking in general about how we do business and how we do things, I think that's going to certainly be something we focus on. I think that one huge transition for us that moving forward, we after 2023, we will no longer be working with the NBME as far as development of our examination, and so we have started working with the ABMS now, and so they're going to be now our collaborators with developing our written board examination. So I think that will certainly be a big transition for us, and I think that there'll be a lot of thinking again and relearning and maybe changing some pathways and processes for that exam development as well. I think that we still need to really look at the maintenance of certification. The WLA has been really popular, and because of that, we now have less people who are participating in our subspecialty written examinations. And so this was a big push developing the subspecialty examinations when I just started the board. And as you may or may not have known, we did not have a shoulder and elbow subspecialty exam. And so it was a big change to develop all of these subspecialty exams, but at the same time, WLA then evolved. And so now we need to rethink, I think, how we do business with respect to maintenance of certification, and maybe in the future that it's possible that subspecialty exams will be offered in less frequency, or maybe some of them will be even phased out. And I think that is something that that we'll just have to watch and monitor. We want to be thoughtful about what our diplomates, what their wishes are, and what they, what their opinions are about maintenance of certification. And we have sent out surveys to get opinions, and that was how we developed the WLA, where we got opinions from our diplomates. So I think that we'll have to continue to monitor and watch that. And then obviously with GME, this is going to be, I think we have a huge potential to look at orthopedic programming across the nation. And so once we get big data, we can actually really start to look at, are we able to very fairly set orthopedic standards and really push the needle with competency-based training? So I think that if we all work together and we get data to show, how residents perform, and we've made some assumptions through, educated groups deciding what should be core surgical procedures, what should be procedures where you only get exposure. We will have the potential to really look at that and see what residents are actually doing out there in the real world, and are they getting the same exposure across all programs to different surgical procedures. So I think that competency-based training is, I think, going to look a lot different, and I, again, I'll give a shout out to all of the partners, because as you heard, there's all of our societies are partnering with us on the project.
One thing Pete and I both wanted to ask you guys about, and I think this has become more intriguing just due to media and what we can see spreading like wildfire through all channels of social media and mainstream media, et cetera. There's been a high-profile case in neurosurgery, or a high-profile surgeon in neurosurgery, with the whole Dr. Death podcast and now TV show. And for anyone who is not aware, just as a brief summary, this is about an actual real-life neurosurgeon who somehow got through all the metrics and all the boards and all the tests that everyone gets through, and became a full practicing neurosurgeon, but had severe complications resulting in morbidity, mortality, and yet continued to be passed system to system without necessarily being policed. And I think, neurosurgery is not too different from orthopedic surgery, particularly as it relates to spine, but just in general, it's a surgical field with high stakes. And I think we all feel that one role for the ABOS is to prevent cases and surgeons like this from slipping through. How does the ABOS prevent the next Dr. Death from being an orthopedic surgeon? David, let's start with you.
Sure, that's a great question. I would tell you that that particular individual was not board certified. and did not go through the board certification process at the American Board of Neurosurgery. Although it has, it's a case that's garnered a lot of attention, and if you go to the American Board of Neurosurgery's website, they have information there concerning that case. But I would tell you that we are trying to put those checks and balances in place, and certainly that's something with the knowledge, skills, and behavior program during residency, because that is a surgeon who did not do the requisite number of cases to finish a residency program, and yet because there were really no tools to help program directors make judgments about individuals, that's a person who sort of slipped through that area. And then I think on the other side, I think we really need to educate patients and institutions about the value of board certification, and that certainly is a glaring example. But if you look at state medical license actions, and this is not specific to orthopedic surgery, actually in general surgery, surgeons who are board certified and recertified have less state medical licensure actions, and they are less severe for that group. So I think that case is exactly why we need really to, again, self-regulate. And our goal, as we move forward, there needs to be a hurdle there. If we don't jump over the hurdle and educate not only our patients but institutions that board certification is meaningful, I think those things can happen. And so we really need to educate those groups. We have a patient-facing website that orthopedic surgeons can give to their patients. It's called mycertifiedorthopedicsurgeon.org, mycertifiedorthopedicsurgeon.org, and that explains what orthopedic surgeons go through to become board certified and what it means to be board certified. It has various videos there from patients and also videos about what it takes to be board certified. And so I think our goal for people who are doing the right thing is to streamline the system, and with electronic medical records, I see a future where we can streamline the process, and if someone's doing the right thing, the hurdle is going to be very low. But I think that case you point out shows us the value of having a hurdle that will trip those people, and that's our challenge. That's our challenge as a board, is to figure out how to make the hurdle, high enough so that the right people trip over it, but low enough so that we don't overburden people who are doing the right thing. So I hope that was a reasonable answer.
That was great. Honestly, both of you guys have been awesome in answering our questions, and I'm hopeful that the average practicing orthopedic surgeon, when they listen to this, will have a greater appreciation for all the work the board is doing and all, honestly, the good that you guys are doing in protecting our patients. So I want to thank both of you for taking the time tonight. This was really valuable, I think, for our listeners, and we know you're both busy, so we really value your time.
Great.
Thank you very much. Yeah, it's great. It's a privilege to be here, and I would just encourage people, if you have questions about board certification, please don't hesitate to call us. If you have suggestions about how we can do what we do better, please don't complain to your colleagues. Call me. I'm happy to hear the complaints, but if you have ways you think we can improve things, please call, because we are really working hard to do things right and pay attention to the details. So thank you very much for having us.
I want to echo Pete. Thank you both so much for taking the time out of your busy schedules to join us on this incredibly important topic. That's really all the time we have for today's podcast. Again, we want to thank our guests. For all of our shoulder and elbow listeners out there, please don't forget to subscribe. And for Pete Chalmers, I'm Rachel Frank, and we'll see you next time.